You are listening to In the Thick of It, a podcast from the HCM Society, where we interview experts in the hypertrophic cardiomyopathy field to broaden the awareness of new HCM studies and advancements. In this episode, host Dr. Sharlene Day discusses an extraordinary topic, the transformative world of gene therapy, with Dr. Carolyn Ho. The conversation delves into the fundamental concepts of gene therapy and investigates its promising applications in the treatment of genetic cardiomyopathies and arrhythmia syndromes. Together, they explore the potential to revolutionize the lives of individuals affected by these conditions, highlighting both the transformative possibilities and the obstacles encountered in the process. This isn't just about science, it's about hope, curiosity, and the journey toward a future where genetic heart conditions may no longer define our paths. Let's get in the thick of it. Here's Dr. Day and Dr. Ho.
So today we're going to be talking to you about cardiovascular gene therapy. So for those of you who are new to the concept of gene therapy, we'll start off by explaining the different types of gene therapy and how these genes are being delivered to the heart. So I'll get started and then Dr. Ho will jump in. So there are several different types of gene therapy. There's something called gene replacement therapy, which is where a normal copy of the gene is introduced into the heart or whatever organ is affected by that particular disease you're treating. In the case where there is a gene that is defective that doesn't make enough of its normal protein. And so essentially you're rescuing the protein level of a particular gene by introducing a normal copy. Then there's something called gene silencing therapy, where you're using typically an RNA nucleotide to silence or turn off a gene that is defective, that's making an abnormal protein that you don't want to be expressed in the heart. And then there's also direct genome editing, and this is where the genome of the individual is altered at the point where there is a genetic variant or mutation that is causing that gene to be defective. And this is accomplished currently by using a technology called CRISPR-Cas9 mediated genome editing. So in all cases, the nucleic acid needs to be introduced into the heart. So it needs to physically get there and get into the cardiac muscle cells and get to the DNA of the individual. And currently the way that that's done is through a viral vector, and the virus is called adeno-associated virus, where the gene or nucleic acid is packaged inside that viral vector. The vector then has a tropism or proclivity for getting into cardiac muscle cells. It releases the nucleic acid inside it when it gets into the muscle cells. And then the virus itself is not competent to replicate. And so it releases the DNA and delivers it, but it's not able to replicate. So it doesn't cause a viral myocarditis, for example. And so that's currently the way that this is, the genes or nucleic acids are being delivered. Gene replacement therapy is the one that we're currently using, and is that particular mechanism is being used in phase 1 and phase 2 clinical trials currently in cardiovascular gene therapy. So, Carolyn, do you want to comment anymore?
Yeah, Sharlene, thank you so much for that incredibly clear overview of what gene therapy really is. And it's probably more correctly called nucleic acid therapy. That's sometimes abbreviated NAT or NAT, but that's far less sexy sounding than gene therapy. Gene therapy has ruled the day, but it's important to recognize that, what we're trying to do right now is all the gene replacement therapy that Sharlene that described first. So it's really trying to bolster up the amount of protein that is deficient in the cell. So this is particularly targeting conditions which are caused by loss of function genetic variants, meaning, remember we each have 2 copies of every gene, one inherited from mom and one inherited from dad. So there's a normal copy that's inherited from the unaffected parent and an abnormal copy that's inherited from the affected parent or introduced spontaneously in de novo cases. And the problem with that abnormal copy is that it's not making enough of the protein of interest. And with hypertrophic cardiomyopathy, the poster child is HCM caused by myosin binding protein C mutations, which are almost the vast majority are caused by these loss of function variants. So only an abbreviated or truncated version of myosin binding protein is made and it's probably degraded either at the RNA or the protein level. So you only have a proportion of the normal amount of MYBPC3 floating around your cardiomyocytes as you would want to have, and that's pumped out by the wild type or normal copy. So the purpose of the gene replacement therapy is to inject normal myosin binding protein C DNA into the cell using these AAV9 vectors and have your cellular machinery express more MYBPC3 to try to raise up the protein level to what might be seen in a normal situation, thereby counteract the effect of having one version of the MYBPC3 gene that's not contributing. So when nothing is actually being done to your genome or to your own DNA, it's just introducing this extra DNA to try to correct what the underlying problem is.
So you mentioned myosin binding protein C and hypertrophic cardiomyopathy. What other types of heart conditions could gene therapy treat? Other types of genetic cardiomyopathies, can it treat acquired heart disease?
Yeah, so in terms of the genetic heart diseases, the gene therapy, this gene replacement strategy has already gone through phase 1 clinical trials with pretty encouraging results looking at Danon disease. And so that's caused by loss of function mutations in the LAMP2 gene. That's a lysosome-associated membrane protein gene. It's encoded on the X chromosome. So males are, have consistent bad disease. Females are often manifesting, even though they have a normal copy of the X chromosome, depending on how normal and abnormal copies of the X chromosome are inactivated in the, particularly in the heart. Females can have disease that's nearly as bad as males. They tend to present and get into trouble a little bit later. But so there has been gene therapy providing normal LAMP2 DNA. With some favorable results in terms of initial safety readouts. And gene therapy has also been used in Duchenne muscular dystrophy to try to, again, provide more functional dystrophin gene. It's a little bit different, but it's kind of the same overall concept.
Right. I think with dystrophin, the one thing that we'll get into are the challenges, and one thing is the packaging limit of these adeno-associated viruses. And so dystrophin is an enormous gene, and so in order to get it to be able to fit inside an AAV vector, there are internal parts of the gene that have been deleted, so that the protein that's made is sort of not quite as functional as the normal one, but it has some of the essential elements to be able to function better than nothing. So these so-called mini or microdystrophins are what's been introduced into AAV. And so far, I believe over 100 children have been treated with Duchenne muscular dystrophy have been treated. And it is the first FDA-approved gene therapy that's being used clinically now. And then Danon, as you mentioned, it's in addition to a favorable safety profile, my understanding is that there was improvement or stabilization of many of the biomarkers in terms of NT-proBNP and LV mass and so forth, and that there was improvement in symptoms of many of the patients, but very small trial initially and moving into phase 2 very soon. And then I think you mentioned HCM for myosin binding protein C. Are there any other trials?
They are, yeah, they're starting to develop trials and looking at arrhythmogenic right ventricular cardiomyopathy, specifically the most common genetic cause of ARVC are variants in plakophilin, which are again truncating variants. And it's the same concept of providing more normal plakophilin. And so those are a little bit behind the MYBPC3 HCM programs in development, following a similar pathway.
And I think one other one worth mentioning is Friedreich's ataxia, which is a neurologic condition, but also has cardiac manifestations and causes a cardiomyopathy that's similar to hypertrophic cardiomyopathy. And I believe that is also in phase 1. So let's talk a little bit about kind of what the ultimate promise and potential for the gene therapy is to impact the natural history of disease. Is cure a possibility?
Right. So that's the holy grail, right? Especially when you're talking about the approaches that actually do modify your DNA. So that goes in, with this little molecular scissors, clips out the genetic variant that's causing disease and inserts the correct sequence. So, of course, that's kind of the ultimate dream, but I think that dream is, quite a bit in the distance. Because there are a number of very substantial technological hurdles that have to be overcome before we get there. But that's, what we would think of as being somewhat curative therapy. And then we also have to think of, if we're shooting for a cure, when in life does that need to happen? When is the ball irrevocably put in motion, even if we don't see obvious imprint of disease? So how early in life are we going to have to treat? So a lot of big questions for that, but that's kind of the big dream. Short of that, the other huge promise of gene-based therapies that the proponents are hoping will be realized is more of a one and done treatment, right? So the other treatments that we have for HCM surgery is kind of one and done, but we know that we're not really altering the natural history or the disease biology when we do surgical myectomy or invasive or other invasive septal reduction therapies like alcohol septal ablation. We're kind of rearranging the morphology and the architecture and can improve the hemodynamics. That's kind of a one-time procedure, but the underlying disease persists. So and for medical therapies, even new exciting medical therapies like cardiac myosin inhibitors, that's probably going to be a chronic fix where you'll have to take a medication every day, probably indefinitely. So with the gene-based therapies, there's a hope that it will be one and done. This therapy is applied, and hopefully that will be durable. I think that the big unknown is how long will the effect last. After a single AAV9 injection, we can have a boost in the levels of MYBPC3, but how long will that be? And that takes us to one of the big challenges of the current delivery system. So, Sharlene had mentioned that one challenge is that these viruses are little and they can only package so much DNA. So, an MYBPC3 is really stuffing them full and kind of meeting the maximum in terms of the cargo size, how big is the trunk that you're able to carry around the DNA. So, the cargo size is one issue. And then the other issue is that you will develop antibodies to the AAV9 vector, the way you develop antibodies to any virus that you're exposed to. And those antibodies will prevent additional doses of AAV9 to boost down the road because they will neutralize the vector. So, you have your one shot getting your AAV9 right now, and how long that will last is unclear.
Right. And, you mentioned some of the really big challenges, and, hopefully these, can be overcome in the future, particularly the ability to redose, because a lot of that is having to do with how long the virus is circulating systemically and in the amount of time it takes to, if it's there long enough, then you're going to develop these neutralizing antibodies. If you can get it into the cells quickly, by some method, then it may not have enough time to really mount the antibody response. But that's, going to be a big challenge to overcome. I think the other things to think about in terms of challenges, in addition to the ones you already mentioned, are, that there's toxicity of these vectors, right? And right now, the cardiac transduction efficiency isn't that high. And so you need pretty high titers in order to get enough of it into the cardiac muscle cells. And that at a certain level, that produces systemic toxicity. And so there's a requirement currently for some form of, anti-inflammatory therapy, steroids and other things given up front. And I think we still don't have a handle on exactly what the right cocktail is and whether that should be individualized for different people. And people can get pretty sick acutely. And if they already have, a cardiomyopathy that, that puts them, in a tenuous position, then that could really put them over the edge. And that, I think, has happened in a few cases of Duchenne muscular dystrophy that has resulted in mortality. So improving the cardiac transduction efficiency with novel vectors that have greater tropism for the heart and less tropism for other organs like the liver, I think is going to be a major focus moving forward to try and improve the delivery, safety, and efficacy of gene therapy.
Yeah, Charlene, those are such great and really important points. This type of therapy is aggressive and it's a big deal. There are real toxicities associated with this, and the risk of mortality is non-trivial, right? and we're battling against a systemic immune response, which may be over exuberant on the host side, and require a fairly rigorous immunosuppressive regimen up front, and the like you said, the actual dosing of the virus at those high titers, the high concentrations that we need now is also a big limitation. And so I think you were hinting at patients that were really sick, perhaps not being able to withstand the potential rigors of going through these gene therapies. That mainly being in the acute time when the people are dosed and may have this like robust inflammatory and immune response. So, what do you think we should be thinking about in terms of the right person for gene therapy?
That is the $1,000,000 question. More. I think, as you alluded to earlier as well, when in the disease course is the best time to implement gene therapy. Now, obviously, if it were completely safe and effective and everybody could get it, we'd want to give it to people before they ever develop disease or in the very early stages, but we're definitely not there yet. And so we're in this position where we want to give it to people who may not have other treatment options, or their treatment options are limited, and they're already, quite advanced. But at what stage is too advanced, either because it may be unsafe for them to sort of withstand the potential acute toxic effects of the viral delivery, or that they may not benefit from it because their disease is too far progressed. Are we going to be able to reverse fibrosis? We don't generally think so right now. I don't know if, that may, not be true in the future, but, there's some aspects of these conditions that we tend to think right now, at least, are permanent and we can't go back. And so I think currently, with Danon disease, those patients do progress very rapidly. So that was a really good first choice, I think, for cardiovascular gene therapy. Friedreich's ataxia is another example because, they really don't have good treatment options. FA patients often cannot get transplanted because of their neurologic condition. And for Danon, it's such rapidly progressive at an early age. And it's fairly predictable, right? It's very high penetrant and rapidly progressive, whereas some of these other cardiomyopathies, HCM, for example, can progress over the course of years and decades, and it's not really predictable who's going to do poorly in the end. Like if we could, use our crystal ball and say, okay, well, we know that you're going to need a transplant in 20 years, this is kind of the window in which we need to do something. But we, as much as we've tried, I don't, and we have some, we've gained some insights in terms of predictors of developing systolic dysfunction, advanced disease. I don't know if we're, completely able to do that confidently.
Mm-hmm. Yeah, so like so many great points packed into to that, just to kind of highlight a few of them. So a lot of times people refer to the ideal candidate, at least for the these initial trials of gene therapy, as being the Goldilocks patient, right? So not too sick that they're either going to have trouble getting through the therapy, or we worry that you're at such an advanced stage that giving you some more, just additional MYBPC3 at this point isn't going to help claw back as much as needed, but not too well that it's going to be almost impossible to figure out if we've had any impact, at least in the short term, and be like exposing people who may never have problems to the risks of gene therapy. So really trying to find where that equipoise really lies, I think is the subject of a lot of hard thought and consideration. And the heterogeneity of HCM also makes it hard because, you'll notice that the earliest diseases that have been tackled by gene therapy are really consistently bad diseases. We know that boys with Duchenne's muscular dystrophy are going to do badly, and so it's worth taking a chance with a higher risk therapy. Similarly for Danon disease or spinal atrophy, so those are some of the conditions where it's it seems like a much straighter path, but HCM is very heterogeneous, and we need to develop that crystal ball, and that's really a call to arms to the scientific community. To try to figure out how we can more accurately predict who's going to do well and therefore we just need to leave them alone, and who's going to do poorly down the line, and those are the people that we want to target for these more aggressive therapy. And hand in hand with that, we need to figure out how we're going to detect treatment response, especially if we're able to, hopefully things will progress well, and we're able to be a little bit more comfortable about the safety of these approaches, and then we'll probably want to start moving the needle back, and instead of treating symptomatic, fairly severely affected patients, do we want to try to see if we can provide therapy at an earlier stage to try to prevent disease progression? And again, the safety will have to be really securely demonstrated, but we're going to need to figure out how we're going to tell we're making those patients better. So we're going to need to develop and identify much more robust predictors of disease progression and therefore of treatment response.
Yeah, no, those are all excellent points, of course. I think in terms of how we're going to predict, what are the endpoints going to be? I mean, a lot of the trials are using endomyocardial biopsy to be able to show that they're actually expressing the protein that you're getting in the heart, because that's obviously critical. If you don't do that, you're not going to have any.
Yeah.
But that of course comes with some safety issues. Obviously, we do biopsies pretty routinely, that it is invasive, and so the early trials at least are going to have to demonstrate that they're replacing the gene that they are putting in, and hopefully not going, making too much of it, right? So they have to also, you don't want to overexpress genes, because that is also not a good thing. So you have to find that exact window where you're making just enough to kind of get it to a normal level, but not too high. And for myosin binding protein C, I think we know from a lot of studies using human tissue, using animal models and so forth, that if you normalize the amount of protein, you really should, in theory, cure the disease. But again, it depends on sort of when you start. So what do the next steps look like, do you think? Where do we go from here? So we got lots of challenges to overcome, but the trials are moving forward. So what do you think we should do? Sit tight and wait for the results for the first trial?
Yeah, I mean, it's super exciting time, right? All these, amazing new therapeutic approaches being considered in HCM. I really never thought that in our careers, that would be seeing this, and all of a sudden here we are. So it's like an amazing time to be involved in this field. Right, we sit tight, we see what happens. Can we transduce the heart in an appropriate way? Not only can we get the DNA in, but can we get a reasonable amount of wild type protein actually expressed, and what does the toxicity look like? So I think that we're all eagerly awaiting this initial experience, and that everything that we learn, every little nugget of knowledge is so critically important to help guide next steps. Charlene, I'm wondering, your patients coming to you and they're saying, what do I do? I'm moderately symptomatic. There's a scenario of people that have obstructive disease. There's a scenario of people that have non-obstructive disease. Like, what do I do? Do I go for, if you have obstructive HCM, do I just get on a commercial myosin inhibitor and, follow that pathway? Do I think about some of the trials going on? When do I think about gene therapy? How does that, all fit in your approach?
Yeah, I mean, I think, it's important that patients recognize what all the options are, and so that's always been my approach. And now we just have a lot more options. It used to be like, well, you can do A or B. Now you can do A, B, C, or maybe D or E. And there are a lot more clinical trials. Like when you and I started in the field, I remember meeting you a long time ago, and we said, like, there were really no trials going on. And so this is a super exciting time to see, how far things have come and to have so many options for patients. So, I think for someone who's obstructive, and like the gene therapy trials are not including obstructive patients, because we do have therapies for those patients, including septal reduction therapy and cardiac myosin inhibitors, to improve at least the component of their symptoms that are related to obstruction. For non-obstructive patients, I think, it's a very heterogeneous group. And so, there's some who, may respond to cardiac myosin inhibitors. That's being tested in clinical trials now. There's some that may respond to, to other medications. There are going to be upcoming clinical trials, I think, for those patients as well, for the non-obstructive group. If they're really motivated to do gene therapy trial, I think it's going to be a very, in-depth conversation. So to make sure that they understand all the potential, challenges, the potential toxicity, everything that we've talked about today, I think we have to convey to the patient in order to, make sure that they are truly giving informed consent to participate. I'm very optimistic that this field is going to move quickly in terms of because there's so many people working hard, both in academics and in industry, on improving the vectors, right, to find those optimal capsids that are going to improve cardiac transduction efficiency, which would allow us to deliver lower titers, which would make the therapy so much safer that I think people would start to feel better about enrolling in the trials, and we would feel better about about encouraging our patients to think about the trials. And I think we're going to see non-viral gene delivery at some point, right, through lipid nanoparticles. We just don't have those yet that can get to the heart, but they can get to the liver very well. And so if they can get to the liver, I'm sure someone's going to figure out how to get them to the heart. And getting around the development of antibodies so that there would be ability to redose. I mean, I think these are things that are all under active investigation, and I'm hopeful that in the coming years that we're going to see rapid advancements in these areas that will improve the safety and efficacy of these therapies.
Yeah. Incredibly well said. Stay tuned. Fasten your seatbelt. There's a lot that's going to be happening that will be, impactful for our families. Not the patients in front of us right now, and also their generation of offspring.
Great. Well, thanks so much, Carolyn. This was really fun to do together.
Right. Thanks so much, Sharlene.